I approached this talk more from the perspective of two things. One, what would be helpful to me if I were a urology resident in terms of some basics that would facilitate a more sophisticated interface for prostate cancer patients specifically. And then also some vocabulary and language. So when patients are telling you what's happening to them, have more of a background. And at the end, a bit of a smorgasbord of some topics that I think are good to have seen. So in terms of off-label mention, this is my recording.
Yeah.
I'm involved in like a random somite mesenchymal company that doesn't have things to do with cancer. And then I hate personalized dosimetry, and I broke my long-standing rule of not taking any pharma trips to go and rail against Novartis's move toward personalized dosimetry. But these are my closures. All right, so always start with this slide, because this is something I hear a lot. People say, want to get the best surgeon, travel, but get your radiation closer to home. It doesn't really matter where you get radiation. So every talk I give in every context, I always show this slide. So to the far left, this is an overall survival Kaplan-Meier plot that compares two types of treatment for head and neck cancer. One is radiation plus chemo, and the other is radiation plus chemo plus a radiosensitizer for a gold star. What does this plot tell us about the difference between the treatment arms?
Relatively similar until 2.5, whatever that is, years out.
Yeah, so with Kaplan-Meier plots, if they cross, you're screwed because your p-value is 0.65. And so these are felt to be equivalent by virtue of chance, really. So these are, this trial was a negative trial. Both arms were the same. But then these Tasmanians, because they're very saucy, they went and actually got the radiation plans from the clinics where these 780 patients were treated. And they blinded, asked for an independent review on a couple of different axes. One axis is like, hey, if you can see the tumor, did the radiation oncologist treat the tumor? So that's sort of an efficacy standard. And then a second standard is, did they do anything that seems like it would be pretty likely to harm people? And that's a safety standard. And then instead of having a Kaplan-Meier plot that looked at the treatment arms, they published a paper which rocked my world, and I love, which is this. These are the plots that show outcomes according to quality of radiation. And I would focus your view on the left, percent surviving, comparing the yellow line and the red line. The yellow line on the efficacy ground is people whose radiation plan treated the visible tumor and how they did. And the red line is people whose treatment plan, in retrospect, failed to treat visible tumor. Now, these are patients enrolled on a clinical trial who went through quality assurance training and knew that their radiation plans were going to be reviewed. And I would point out that there is a 20% survival benefit at 2 years among people who got radiation with good radiation oncologists. So not all treatments have equal complexity, but it does kind of make my heart hurt when I hear people say, like, it doesn't matter, which just it's not true. It does. All right, so learning objectives. Next, radiation basics. So over the last 15 years, most of what has changed in radiation oncology on the ground is related to technology. And there has been an explosion and proliferation of hardware advances, software advances, This has really altered how radiation is delivered and has created more variability in terms of what radiation oncologists do, which I like to say, this is not your grandpa's. Speaking of that, another slide a frequent flyer. Does anyone know who the woman to the far right is?
Marie Curie.
Yeah, so she is the only human in the history of the world to receive Nobel Prizes in two separate scientific disciplines, credited with the discovery of radiation as a thing, and then the molecular crystallization characterization of radium. What about the kid in the middle? What's his problem?
Is that a goiter?
I don't see any goiters, only cancer in Kendra's clinic. This is an old school picture of a kid with Hodgkin's lymphoma, which was the first pediatric cancer that was cured. It was cured with radiation alone in the 50s. There are terrible consequences of treating all of the lymphoid tissue in children. But this was the first sort of clinical scenario where radiation at Stanford was brought into the oncology clinic. This is another thing I'm asked a lot, which is why doesn't the radiation cause my normal cells to die? Or the lovely variant of radiation is really toxic and I will never take it. This is how to understand how we get a therapeutic window. The goat with the beret is to remind me how it was that we came to give treatments 5 days a week, or sort of understand that you could achieve certain outcomes by taking a total amount of radiation and breaking it up into small packets and delivering it over time. The original idea here was that you had a ram that you wanted to sterilize, and if you took a radioactive rock and stuck it against the scrotum, they would be sterile and dead. Or you could take that radioactive rock and hold it up against the testis for 10 minutes, 5 days in a row, and they would be happy but sterile. And it was the first demonstration clinically that the effects of radiation exposure really have some relationship to total dose delivered at a particular time. We now know that the mechanism that radiation confers its lethality is related to causing single and double-stranded DNA breaks. And all of our normal cells have a lot of equipment to help repair those because we live in a dirty, toxic world. And so we have a couple of different types of DNA repair machinery. There's error-free, or when you have a single-stranded break and you use sister strand to close that up, and double-stranded breaks where you use an error-prone type 1 and type 2 DNA repair. When you give radiation each day, both the normal cells and the cancer cells have DNA damage. And overnight, the normal cells employ DNA repair to fix the problems, but the cancer cells, which have given up many of the DNA repair pathways across a wide range of tumors. That's why, I only have one tool and I treat a lot of different cancers with it. When you get rid of DNA mutation repair machinery, it makes mutation more likely. And then stochastically, more mutation makes it more likely that one by chance will confer a growth advantage. And so all cancers are enriched for impoverished DNA repair, like BRCA, for example, very important protein related to one of the two DNA repair pathways. And if you're missing one somatically, you basically are given a handicap in developing cancers related to having a higher frequency of mutation. Anyway, so both the normal cells and the cancer cells are damaged overnight. The normal cells repair, and the next day, the cancer cells can't. You give another dose, and you get this, widening therapeutic window where normal tissues are going to be okay, but your treatment is increasingly lethal to the cancer that you're targeting. Incidentally, what are some side effects in the short term that y'all have seen related to radiation in the short term?
Fatigue.
Lower urinary tract symptoms, maybe?
So they get urea. What else?
Fecal urgency.
Fecal urgency, sure. If people have diarrhea, any of y'all seen a penile cancer patient right at the end of radiation?
No.
Right. Skin? Anybody seen skin toxicity? Radiation?
Hmm.
I'm having a hard time hearing.
No, I haven't seen that.
Yeah. Well, I guess the GU organs are largely deep. In any event, symptoms that come on during treatment and the immediate aftermath tend to arise in tissues that have a high amount of turnover. That's because the radiation that impacts those tissues, if one of those cells with high turnover happens to be dividing, the DNA damage, and that normal cell just doesn't have a chance to repair before the replication fork gets stuck, that normal cell will die. So skin, GI tract, urothelial mucosa, oral mucosa, high turnover tissues tend to be responsible for the acute side effects of radiation. In terms of the clinical flow for radiation oncology, it's like Mars. My work has two main components. We have the clinical visits and then the process to create radiation plans for patients, which is about basically a stepwise process of saying, hey, I want to treat a person, and then scheduling something that we refer to as a CT simulation. This is an example of a head and neck one, where the goal is to create a reproducible position that a person can sit or lie in, that we can then do a scan, supported by custom immobilization. And that's the scan that I use to create, to start the process of creating radiation plans. In order that when they come each day for treatment, we can do verification imaging and then deliver precise treatment because we have a custom immobilization. Go ahead.
What do you use to immobilize the pelvis for prostate?
Yeah, so we use something called a double leg immobilizer. I was trying to pull a picture and just ran out of time. A DLI. Because actually, when we have something called a vac bag. You want the pelvis to have minimal tilt. Now we can account for that tilt, but it's better if you don't have to. Let me see if I can pull this picture and show y'all. This right here. You able to see this blue thing? Or do I need to move? I probably need to move it onto my screen. See that?
Yes.
Okay. So on the treatment table and on our CT table, there are notches that are a way to index. Index means that on the bottom of this blue foam thing, there are bars that can be fit into particular positions, both on the scanner table that we use, select the scan, and then on the treatment table. And each person has a description of what their immobilization is like. In this case, we use this double leg immobilizer where you've got the two slots for the knees to be over this first notch and then the lower leg to run through the center of the openings. And the description will be like index on this, on A1, and then whatever the rest of the immobilization is. The process of actually delivering the dailies would be to put this onto the treatment table indexed appropriately, put the patient into the immobilization that's been designed for them. And then there's a CT scanner bolted orthogonally onto the linear accelerators. That comes out, you take a single slice CT scan. You can use a separate computer program to account for and correct for 6 degrees of freedom, small changes, correct tiny rotational problems. And then you also use that scan to evaluate the fullness of a bladder or an assessment of whether the other soft tissue are appropriate for the daily treatment. Does that address your question?
Yes, thank you.
Oldest school, so you know, like, when do you guys think CT scanners became available widely? The decade, maybe a decade.
The 90s.
80s.
So prior to the 80s and through the 80s, radiation oncologists literally took x-rays, got a red crayon out, and drew using bone anatomy. And then radiation was prescribed using first principles about would calculate an amount of radiation based on how thick something is. If that thing were all water, crazy. These are fields designed by a mentor at Hopkins. These are fields for a nasopharyngeal rhabdomyosarcoma for a 10-year-old treated in 81. You know, it's crazy. When CT scans became available, we had rudimentary ability to see things and approach them in 3 dimensions. And so began the journey of, I could decide, hey, I want to bring radiation in from the front or the back or the side. And then the CT scanner, in conjunction with computer software, could model how the different densities would modulate the deposition of radiation with a field that you designed. That's 3D radiotherapy, acknowledging the critical role of CT scanners. We still do 3D radiotherapy in a variety of contexts, and there's a lot of increased fanciness that make it much better. But the general principle of 3D is that you, as a doctor, design how you want the radiation. Then just trying to some framework for all the alphabet soups, right? The big game changer came with the integrated development of basically advanced hardware so that you could control exactly the opening through which radiation came. Advanced software where you could use the CT scanner to create targets and avoidance structures, and then computational ability. So this IMRT or VMAT, rapid arc, etc. It all refers to an approach that is basically the reverse. So you as a doctor are saying, I would like the prostate to get this much, while the rectum is not given more than this amount, and the bladder is held to this amount. And here's the shape of this prostate, and here's the shape of the bladder. So you tell the algorithm what the contours are of your whole landscape. And then the algorithm just churns. I mean, a typical prostate plan is the result of about 10,000 iterative attempts to arrive at whatever set of goals or particular radiation oncology that's out. And it is this increased technical and software complexity that has allowed a real revolution in terms of that therapeutic window being widened, both because you can give higher doses safely and because you can more effectively limit the dosing of critical structures when you need to. However, radiation is not like money. It's not like 4 quarters equals a dollar. And to the right of the screen is 3 approaches that really have been shown to have equivalent kill power for cancers, right? So you can give 78 units of radiation, 2 units per day over 9 weeks. And that has the same kill power as 27 units of radiation given in 9 units per day over 3 days, or you could give 18 gray all at once, which is to say that it's not enough to know how much a person got. You have to know how it was delivered. And that's just another thing to keep in mind when you see patients at various treatment. Sort of next step beyond that sort of technically complex treatment that I just described is referred to with another alphabet soup, SBRT, SABR, SRT, SRS. There is a fair amount of things being deployed in clinically localized prostate cancer with pretty limited long-term follow-up data. There's also a very rich and I consider pretty exciting literature for management of oligometastatic disease. This is basically the last thing on steroids. We've developed such ability to have precise delivery and a very rapid fall off, leveraging all the things I just discussed. You can just really dump a huge amount of dose that will locally control lesions with limited risk to surrounding structures. And the relevance of this for prostate cancer has increased as our ability to see lesions at smaller and smaller sizes has improved. Y'all are familiar with PSMA PETs. It's really our ability to better and more accurately risk stratify and categorize men. That for me is the big value added PSMA scans. I find that this is a helpful rule of thumb, especially in the salvage setting, about, if you had a PSA value of X in somebody who shouldn't have any prostate cancer in them, but has a biochemically detectable PSA value, what is the likelihood that a PSMA scan will show you a site of, and, I tell patients that at about 0.5 PSA, nanograms per milliliter, you have about a 50% shot of seeing the disease or seeing a site of disease if you go ahead and do this. Something to keep in mind when it comes to, at the very end, I just make some comments about early salvage, etc., and how we have incredibly improved our ability to see smaller collections of prostate cancer deposits, but there's still a lower limit. I'm going to skip this, I think. And then in a prostate world, I am frequently asked about proton therapy. And this is like a case study in direct-to-patient marketing. And everything that I talked about up until this moment is delivery of a type of radiation called photon radiation. They're waves, they're particles, they're both, they're neither. It is basically machines that take electrons out of the socket, electricity electrons, and speed them up and slam them into a heavy metal target, and then an array of photons, which are then directed for treatment. Proton therapy, very different. Protons are actually particles that are charged in the middle of these enormous machines. They have a little bottle of hydrogen, this thing ever. They pull the hydrogen atoms out and use the charge to speed them up similarly. But they have an unusual and highly leverageable characteristic, which is that they enter and then they deposit most of their energy, and then they do not exit. This gray picture here. This puppy out the way. This gray peak is a famous third brag peak. And it's basically, when you leverage this type of technology, you have the benefit of no exit dose. You'd be like, why would I not do that? Like, that sounds awesome. It just turns out that there is a different type of complexity introduced, a different set of uncertainties introduced with this type of radiation, which is much more vulnerable to small differences in tissue. It also turns out that Medicare, in their infinite wisdom, decided that treatments such as these should be priced at the proportion total cost of whatever the equipment is. So if the equipment is $100 million and the expected life is X, proton therapy is going to be reimbursed at 100 million divided by X. So in the early days, especially, the reimbursement for the technical component of proton therapy was basically a 10-to-1 relationship with standard radiation, which is an incredible business model that Loma Linda pioneered. It also, due to the incredible cost in the early days, although they're now miniature units, and there are situations where proton therapy is long diggity, it was a real disincentivizer to participate in clinical trials, looking at even basic safety questions, but certainly efficacy, because you really do have a pretty high mortgage on those types of units. But the VA finally provided guidance because VA guys were like, our country doesn't love us. They won't pay the extra cost for the proton therapy. And they commissioned an important set of comparison assessments using their VA in Philly. And the bottom line is that men who were treated with proton therapy had very significantly increased rectal toxicity, and in particular, a tripling of their rectal bleeding, a doubling in the rate of urethral stricture, and an increase that was significant in the rates of hematuria. Which, since the proton therapy is usually marketed to men with prostate cancer, super low toxicity, was kind of an awkward finding. This is the reason why I would say that I'm not aware of any proton centers that allow men to get proton therapy absent the placement of a space ore. We can talk about it if there's interest. And it's the reason why I'm not personally a big fan. So I've worked at places that offer proton therapy. I've given men proton therapy for prostate cancer, but it's usually like me being like, yeah, so, toxicity seems to be worse. Our technology has advanced a lot in the standard way, and men are like, the Brotherhood of the Balloon has told me, Uncle Joe and my perusal of the internet declares that proton therapy is superior for prostate. Okay, so next 10, 12 minutes is the overview of what men hear from me when I see them for prostate cancer in the definitive setting, focused mostly on the guidelines and then just generally my view of the Gestalt literature, which is vast and filled with a range of opinions that can be supported by pretty high quality evidence. So there's not one yellow brick road here. And I'm just going to give you my perspective from the radiation oncology, right? First thing is, when men are diagnosed, I always pull up that actuarial table that the Social Security Administration has because I love it. It reminds me that people who are well in their 80s, they're not like the people who die young, because through good luck, good living, and good genes, they are well at 80. And so if you look at the life expectancy among 80-year-olds and among 90-year-olds, it way outperforms your perception, which is, oh, the average man in the United States lives to be X or Y. And it tends to lead you to underestimate the longevity of particularly octo and nonagenarians. And so that is an important step that I always take. And it's part of the guidelines in terms of helping you think about what is reasonable among the newly diagnosed. Way back in the day, I walked uphill both ways to school. There were just three categories: low risk, intermediate risk, and high risk prostate cancer. And although the general contours here are the same, which is that we care about the absolute PSA amount, Lisa for, and the assessment of whether there's disease outside of the prostate, which we now mostly use multiparametric prostate MRIs for the local and SV assessment, and often use PSMA PETs for the regional and distant assessment. There are more categories which over time have continued to change related to bifurcation of that intermediate risk group, which is, I think, the most heterogeneous of the risk groups even now. The delineation of the very low risk group and guidance related to who to avoid treating entirely. And then the differentiation even within high risk between very high, and there's even further differentiations that are coming, I think, as the high risk trials have validated a couple of biomarkers. From my perspective, the guidelines are clearly supportive of PSMA PETs from unfavorable intermediate risk up. And some payers will pay for favorable intermediate and low risk, but the guidelines really start in this unfavorable intermediate risk group, which is PSA. Basically, you're only allowed to have, if you have more than one intermediate risk factor, you will end up in the unfavorable group, which can be 4+3 disease, or greater than 50% of the sample cores being positive for cancer overall, or having more than one intermediate risk group. So if you had a PSA of 15 and a Gleason 3+4, you have two intermediate risk group features, and that puts you into unfavorable intermediate risk group. Okay, and then just a brief comment about what is to follow, which is just my perspective. And there has only ever been one randomized large comparison of radiation and surgery for definitive management. There have been truly enormous radiation trials that provided long-term data and very large, mostly cohort studies done at large, high-quality institutes, surgical outcomes, and the NCCN guidelines treat every single risk category as a bit of a buffet. Choose your own adventure, gentlemen, because for every single risk category, you have the options of operative and non-operative therapy on the list. And so, especially when I'm meeting somebody for the first time, I say that the national guidelines would be unlikely to offer you a buffet if there was unequivocal data that surgery was better than non-operative therapy, or that non-operative therapy was better than surgery. And so most men make decisions about their choices in conjunction with professionals. And there are some general pillars that I use, which is that generally, the complication that I hear men afraid about for surgery is the risk of urinary incontinence. On average, not in your hands, but on average, the risk of having permanent urinary incontinence is age related. So the younger a man is at the time of their surgery, the risk of permanent incontinence drops precipitously, which is one very good reason to send all men surgery that are young. And for me, that's men in their 50s and down are young men. Very unusual for me to give definitive radiotherapy. Maybe in 15 years, I've given it to half a dozen men for other reasons. Similarly, since it's an age-related risk, and over the age of 70 think it's reasonable to think about non-operative therapy, having the advantage of carrying a lower risk for urinary incontinence. I'm not persuaded personally that there's a huge difference between sexual outcomes. The mechanism and temporal expression of impact to ED are very different. And on the surgical side, depends on whether you can have robotic, whether you have disease which allows for bilateral nerve sparing procedures. On the radiation side, you think that the mechanism is sort of impairment of the vascular supply to the nerves for potency. So vascular paths are likely to have worse outcomes in that regard. But I don't find that erectile function is a very good way to differentiate one versus the other. Overall, I tell men that in average hands, it's not a good hard differentiator. And then on the radiation side, the great risk of, in particular, bleeding in the bladder and bleeding in the rectum is a risk that is just not part of surgical risk. And so for those who do not do surgery and do radiation, we do things sometimes to reduce the risk of bleeding. And then the final risk, which is, you cause scar tissue. So doing surgeries after radiation is harder, and you confer a tiny risk that the radiation you give would cause another malignancy down the road. Now, the latency for that is generally 10 years, and histology is something other than what you had. Typically sarcomas, they're hard to cure, but it's clear that getting radiation also confers an increased risk of adjacent cancers that are not sarcomas. So increased risk of bladder cancer, rectal cancer, and we've had a couple of tumor-borne patients. And this issue of timing seems to matter a lot. So if you're a man in their early 50s, the risk that getting radiation would cause a cancer, which is an actuarial risk, which means there's a tiny risk every year, and your absolute risk is the number of years you live with that tiny amount multiplied by that number. You give a very young man a much higher absolute risk by deploying radiation. You also just know less about what's going to happen to that guy in terms of other medical issues over time. Okay, so I am presenting the data that is the only actual prospective randomized trial that looked at surgery versus radiation. I'm going to comment on its limitations and findings and then move on, which is, of course, not a trial that we could do in the United States because US men are not going to be randomized between surgery and radiation, but was designed to look at quality of life outcomes and in particular acute and late side effects. And the sort of gold star bottom lines from the initial presentation of this data, which was in 2020, was basically that surgery causes fewer problems in the bowel in the short term and in the long term, which we just chatted about. And also that over the long term, you do have to worry a little bit about the impact to the sphincter complex from radiation over time. So fewer loose continence in the surgery arm. And then here's the bloody stools that I just mentioned in my last comments. And then further, when you have a surgery, tend to have fewer outflow issues related to just these are patient-reported quality of lives, and less nocturia. And this is, as you can see, over 5 years. So it's differences that persist over time. And then similar to our lived experiences, on average, getting radiation less likely to result in some amount of difficulty with control of urine. And the ICIQ is a composite score that looks at a number of different ways to think about what how to measure urinary incontinence. And then this is what they published related to erectile dysfunction. And they compared 3 arms of this trial, which included active surveillance, and noticed that sort of self-reported subset of ED-related measurements. And the 2 things to know about this trial, if a rad onc ever tries to wave it around, is that like 80% of these men did not have robotic prostatectomies because they had operations in the UK, and robots are expensive. And so one way to respond to this is just that, okay, well, fine. If you have an open prostatectomy, then yeah, your sexual outcomes aren't going to be as good as when they do a bilateral nurse sparing. And then the other component of this is there are a lot of different ways to measure and quantify erectile dysfunction. This is a patient-reported outcome composite score, which better than nothing, and neither is it an absolute truth. So again, I tell men that I don't find that outcomes from erections is a very, very good differentiator. Okay. Also, this part is when we give radiation now for just treating the prostate, men are now more commonly treated over 60. There are very large trials that look at that. And there has been a real explosion of giving that sort of high dose with a few number of days, so-called SBRT, to the prostate on the basis of it being so much more convenient. Or if you spent a lot of money and invested in a ViewRay, which is MR-guided radiotherapy, brag about how much better it is, and you market that to patients. My main feedback about that and what I tell men generally is that the length of high quality outcome data for this approach is not great. We have very, very long-term follow-up for surgery with medical condition. It's also true that the complexity and technical requirements of this type of treatment, given what is on either side of the prostate, are much higher. So the very, very worst radiation-induced injuries that I have seen, patients that see me who got treated elsewhere, are all, for prostate, are related to this treatment. Because if you're half a centimeter off, you are blowing a hole in the rectum. And then this is a technique that came out, and there are many centers that maybe are trying to implement it, but they've been in solo practice. It's just a higher risk undertaking. I'm trying to think in the last 10 minutes. So I can talk about, you guys want to, well, basically, I will more quickly summarize and try to finish the localized prostate briefly, which is that I spend a lot of time worried about this intermediate risk group. Generally, I deploy, this is the one group where I am very likely to send additional assessments. And that's because on the radiation side, and who have favorable intermediate risk disease get radiation alone. And with unfavorable intermediate risk disease, really need hormone blockade. And that is something that most men are not excited about. And so there are now a couple of validated tools that can be deployed to help kind of gather some additional information about a particular man's typology, whether regardless of Gleason or PSA or multiparametric MRI, does the genetic signature or the histologic appearance, because there are now 2 approaches, looks more similar to men who did very poorly, such that therapy intensification is warranted, or does this man's particular cancer actually look more like men who did very well, in which case you can get the hormone blockade. In terms of high risk disease, I would say that this is a place where my views on this have changed over time. When I trained, we were taught that high risk disease should really be managed non-operatively. And there was a lot of work done over time looking at the duration of hormone blockade, etc. And as our colleagues in medical oncology have gotten better and better and better at keeping men alive, frankly, you have oligo progression and then development of castrate sensitive, castrate resistant disease. Like that pendulum that swings back and forth, that the better our medical colleagues are at keeping men alive with metastatic disease, the more the local control becomes important. And one thing that is true about very high grade prostate cancer, it is just not as well controlled with even full radiation and hormones, especially bulky, not as well controlled with definitive radiotherapy as it is with surgery over time. And so I would say that brachytherapy is something that has really fallen off, except in a few centers that are sort of obsessed with cherry-picked data. There's not as much opportunity to do it in the community. When you have high or very high risk men, especially men who are young, and especially men who are biologically young, this question of, do I need to worry about the local and regional control 10 years from now, 15 years from now, even if they develop metastatic disease, is very much more germane now than it was when I trained. The other thing to know about the high-risk disease group is that the proliferation of trials looking at multi-agent androgen blockade in addition to radiation is maturing. And there are validated rules for some risk stratification tools in the high-risk group as well. All right, got maybe 5 or 7 minutes. Adjuvant salvage, early salvage. Since I have worked with many of you for some time, I'm a fan of early salvage, and I'm mostly not a believer in adjuvant. I think that the data is pretty clear that after surgery, when you give radiation to the prostate bed and pelvis, you arrest whatever recovery surgically is happening. And so it is important to wait until patients plateau, unless there's some hair on fire problem, which really just doesn't happen. With the advent of ultrasensitive PSA and the idea that men should reflexively go from surgery to radiation, even when PSA is persistent after surgery, is something that I, over time, have moved further and further away from, because I think the effects of arresting surgical recovery are not balanced by any measurable benefits of deploying radiation a little bit earlier. And I will leave it at that. Other things that I have in this PowerPoint, if you guys have interest, is a short discussion about theranostics and data about the basically significant benefits of targeting oligometastatic or oligoprogressive disease with dose escalated radiation. It's always important to pay vision trial is a look at the data that emerged related to PSMA lutetium, which is a molecularly targeted radiopharmaceutical agent that Oliver Sartor was the author in the New England and got FDA approval. And other questions that I can come back on at any point. If there are questions or we want to spend the last 5 minutes or 10 minutes or however much time we have with questions or thoughts, I would warmly welcome it.
All right, questions, guys?
Yeah, so Dr. Harris, you talked about salvage in the after surgery. How about after radiation? And can you comment on SBRT versus like medical therapy in that setting?
Yeah. So I would say a couple of things about that. So the long-term data that we have, the very long-term data, suggests that and the reason that a buffet approach writ large is available is because despite the fact that with prostate surgeries, something 15 to 20% will be margin positive, and in some hands more, and only some subset of those go on to develop biochemical failure, which is one part of the story about why I have moved way away from adjuvant. I think there's value to letting men declare. Radiation deployed in that context to the prostate bed, and I am a person who believes in pelvic treatment unless there's a clear contraindication. Basically is a second shot at cure. And over time, we now know that radiation to the pelvis and prostate bed, plus a short course of neoadjuvant concomitant and adjuvant hormone blockade, is superior to radiation alone in the salvage setting. And that is the standard of care. And so when men have margin positive prostatectomies, the subset that recur are given a second chance at being cured by deploying this hormone and radiation strategy. Now, when you give definitive radiotherapy, you do not have a plan B salvage local therapy option. There are urologists that are known around the country for being particularly gifted at post-radiation prostatectomies, but they tend not to be pursued. And there's a number of different criterion that I've heard urologists use to figure out who they're willing to operate on when there's been a local failure post-radiation. The point I would make is that if those local failures in the radiation category happened with any amount of frequency, that difference in whether you had a plan B or not would translate to differences in outcome. And it doesn't. Very, very, very large data sets. You do not see that radiation performs worse in terms of likelihood of cure when you have one option that is surgery and there's a salvage available, and another option is radiation with no salvage available, and the outcomes on average are the same. There's only a few ways that can be true, and the way that can be true is that it's just really uncommon for men to have post-radiation failures that are isolated historically. And that is partly related to just, you don't have to decide where to cut, right? You're able to be more generous when you give radiation.
So you're saying that they don't recur in the prostatic bed if they've had radiation?
I'm saying that in the context of giving definitive radiation to an intact prostate, we don't think about salvage surgery in the same way that we think about salvage radiation as something that can happen, that you can actually estimate your risk based on pathologic factors, and something that men need and can be cured by receiving after surgery, the radiation and hormone blockade. By contrast, men who get definitive radiation to an intact prostate, we don't think about oh, well, when the radiation fails, you can just have a surgery. That is not a pathway that is common. Would you agree or not agree?
Can I make a small comment on that? So to me, the bigger problem is a lot of the patients that recur after radiation often are never even checked to see if they have a local recurrence. So, whereas for us, some of the recurrent, either we're following the patient long term or the recurrence happens fairly early. Some of the recurrences might happen, a few years out. They're being followed by their PCP, their PSA gets, like people aren't aware of what the PSA values are. And I've also seen a lot of them where, even if everything else and they do realize that there's something going on, they just immediately go on hormone blockade and don't get any imaging or anything else to check. So the first thing I'd say is, if a patient has radiation and you suspect a recurrence, it is worthwhile to image them and see what might be going on. And once in a while, if you do this, you will find a local recurrence. And whereas you're right that, like having somebody undergo surgery for this sometimes is a bit much. So I would do it you said you don't radiate many men in their 50s, but I've seen men in their 50s who get radiated. And then if they have a recurrence and they're still young, those are the ones that I would take and do a salvage prostatectomy. But the average patient where you're seeing this is like in their 70s. And if you have somebody that's a good performance status in their 70s, has a local recurrence, we do have, as you guys have heard, we have a lot of focal therapies that can be done. This is I think where, cryo, HIFU, IRE, some of these things can be done where the patient, is not going to have a major side effects, post radiation and now post a focal therapy, but you can still salvage something in the prostate. So that's the way I think about some of these patients. That's the way kind of we do it. Yeah.
I guess the point that I was being too loquacious about is more of a philosophical point, right?
Yeah.
That generally, relative portion of people after surgery that need radiation, isolated local failures after radiotherapy are not common in that way. That's just a philosophical point.
Yeah.
To Dr. Queso's point, I think that is probably even in that when PSAs don't behave, I think historically there has been a rush to put folks onto hormone blockade, which sort of gets in the way of doing a more careful assessment of distant versus regional versus local. And then I think the third thing goes back to that pendulum, which is that the longer men live, the more time that radiation has to render control. And so I think it is true that identifying radiation, post-radiation recurrences certainly feels more common, and whether it's better tools to assess the prostate, whether it's the Stampede data that management of the primary matters, whether it's just men surviving longer, even with metastatic disease, that go on to locally fail after local prostate management with radiation, even if they have low volume metastatic disease. I totally agree that careful assessment of the local situation with imaging indicated. We don't give any tumors higher doses than we give the prostate when it's in place. So as a general approach, I think that reirradiation for a local failure is not wise. And I've seen the SBRT data. I have looked at the brachytherapy data, and I'm not sure if I believe it, to be honest. And so my strong preference, if you have a person with a post-radiation failure, is to send them to the best surgeon you know and not reirradiate. Because things have changed on the surgical side as well in terms of what's possible. And If radiation didn't work the first time, it's just really hard for, I just think, I don't understand the groups that are really focused on trying to re-radiate, because I agree, things like HIFU, there are other local therapies that you can employ, uh, or surgery options have expanded. I was just being kind of slow at getting to my conclusion.
Tell us something about the complications, long term that you'll face.
Yeah. I think the biggest long-term risk of the radiotherapy is bleeding. So for men who are not cured, who were treated definitively with radiotherapy, who go on to need lots and lots and lots of treatments, rectal bleeding and bleeding in the bladder is very has been a part of the deaths of most of the men that I've gotten to know well during the 6 years at Tulane, that they got treatment 5 years ago, 8 years ago, whatever. Maybe they would very intermittently have a little hematuria or a little bit of hematochezia, and you'd cysto them, and yeah, they've got some telangiectasias on the bladder, or you do a proctoscopy and you can see the telangiectasia on the anterior rectal wall. But when their platelets are tanked and they are not producing, especially the guys who develop liver mets, the unmasking of the way in which bladder bleeding and rectal bleeding incredibly harmful, disruptive, and life-threatening should not be underestimated. With respect to the rectal bleeding, today I did a space work at EJ, and that's a part of my practice that has changed over time. Used to be more agnostic about it, but I've tended to do space wars for most of the men I offer definitive prostate radiotherapy to now, because it takes the average risk of 12-13%, which is really like a 3-year late toxicity assessment, not an index reflection of what the lifetime risk is for men. And it can take it down 75% by having a temporary increased distance between the prostate and the rectum. In the bladder, though, you're really limited in terms of what you can do in terms of absolute risk reduction. And I think that in the same way that my view of focal therapy is influenced by the fact that I only meet the focal therapies that don't work, I have a feeling that if I had the full perspective, even if we just limited it to my patients, of the hematuria that y'all deal with and the carry-on consequences over time. Similarly, my GI colleagues, it is not as transparent as it should be, and it's a very serious and important set of toxicities to avoid and to assess. And again, a reason why, men certainly, let's say, to me, 50s, I don't radiate. Like, I'm not like a super hardcore get definitive radiotherapy. And over time, that's been influenced by the long-term survival data in terms of how much longer men are living, etc., with even with the spread. And also, just asking careful questions about the perioperative risk versus, if I think someone's going to end up with radiation anyway, because they're going to biochemically occur because of their disease status. I don't know. I don't know if I addressed your comment, just that not trivial. It's really the late stuff that gets people into trouble.
Sorry, I have a question, quick question. maybe I missed in your presentation. Do we still have a place for combination therapy of brachytherapy and EBRT? Because I have seen a couple of cases they came after this combination therapy, they came with on one hand, very overactive, not responding to any medication, the overactive bladder. And on the other hand, they had incontinence. So your hands are tied. You cannot do the sphincter for them. I don't want to put the indwelling catheter for these patients because they're very prone to fibrosis after a while if you put an indwelling catheter. The only thing that I could do is doing the CIC for the patient, at least for 1 year, because I don't want to do anything before 1 year after this radiation. So do we still have that combination therapy, or it's just the old?
Yeah, so it depends on who you ask. So historically, brachytherapy, which is surgical implantation permanently of radioactive pellets into the prostate, is a low dose rate form of permanent brachytherapy. And when this was developed, the technology from a radiation standpoint, external radiation, was still very much in the 3D era. And so developing an approach that really limited damage to the surrounding tissues was very sought after. The original isotopes of iodine and palladium were an approach that delivered even that permanent radiation kind of more slowly over time. And there was a technical component of this approach such that it was really led by maybe 10 centers nationwide that had very high volume programs. And they did a fair amount of their own publishing, large case series, large multi-institutional, but it was really like the same 10 guys that did hundreds of low dose rate permanent prostate implants. And so you have the side effects of an operative procedure, except, you're typically putting 90, 100 radioactive pellets. And the main difference in the short term is that men are much more likely to have very, very explosive LUTs, more at risk for obstruction due to swelling, either in the immediate term due to bleeding, but the dose of radiation is just much higher. So urinary frequency, urea, urethral ulceration, in nocturia, polyuria, and then risk for stricture, risk for permanent urinary irritation was being considered in trade-off to less sophisticated external radiation. And then it was sort of developed by this centers of high volume. And as the external radiation got better, and then as things changed nationwide about the relative role of surgery and radiation, etc., I would say that there's just less low dose brachytherapy being done. Similarly, hospitals and clinics don't like to do what's required to keep those speeds available. And so there's also an approach called HDR prostate brachytherapy, which is offered like at UAB, a very high volume of HDR brachytherapy for prostate. And that's like temporary radiation implants, launched in the same way that cervical cancer made the transition to high dose rate brachytherapy with very little data, but it appears to work almost as good. Still causes a lot of very impressive urinary irritative symptoms. And this same sort of group of a core group of people who really believe in brachytherapy published an important set of trials looking at high-risk men with that combination. That it's um, showing that in the men that they approved, that if you did brachy plus external beam plus hormone blockade, you could reduce your local recurrences as compared to external beam.
That's being used less and less because we all remember Dr. Ragdi up in Seattle.
Yeah, right.
Really lasted a lot of those. And I still got two of those in my practice because they said, we want to go there and get it done. I said, go. And even today, they say the worst decision of their life in terms of severe bleeding, incontinence, lower tract symptoms, up all night, even today. So to answer your question, there's those who started about 20, 30 years ago saying I can do this both, stopped doing it because of the huge complications that came back to what happens is they went to Seattle and everything's okay in Seattle. They come to New Orleans and two of them are Upper Creek. And then two of them are in Shreveport, Upper Creek. Another five in Atlanta, Upper Creek. But everything is okay in Seattle, which is where it started. So very rarely will you now see a full-blown 82 seeds and then external beam radiation. It was way overkill.
Yeah, so I would say that like any technical, surgical, procedural activity, volume matters first. And second, to me, the lesson of those high-risk trials is those men should have surgery, right? We know that there are high volume, high risk men that fail earlier after radiotherapy, despite my assertion earlier in our talk. And those men should go to surgery, right? But there is this sort of cabal of people, and there's prospective data showing the advantage of adding a brachy boost. But to Dr. Thomas's point, so first, I don't dabble. I do not do brachytherapy. I don't know my colleague Dr. Padman does, but it's just fallen out of favor because the external beam technology has gotten better and volume really matters. And if you've ever taken care of, to Dr. Thomas's point, somebody with terrible, serious permanent damage from that, it makes an impression. But the prospective data looks amazing. Like if you want to see, if you're a guy, you get on PubMed and you're like, how will my erections be safest? You should really look at the data published by the brachytherapy groups nationwide. It's crazy. I just don't believe it. And if you drill down, most of that data nationwide emanates from like a pretty small group of very high volume practices. So if you have some reason that you can't have surgery and external beam is very high risk, I think it's reasonable, but you need to go to like one of those 10 clinics because you can't, it's just not safe. I'm soapboxing it.
Guys, you don't have any other questions, comments?
Thank you.